Okay, we're going to try this again. I just got through about 2/3 or 3/4 of the presentation and all of a sudden it shut off. So we're going to try this again, okay? And what we've done so far in our videos is we've talked about bone location as well as about bone structure. But what we want to talk now about is a little bit more about bone composition, how bone's made, okay? And this is important. These are some very important things to understand, okay? First of all, I need to talk about how bone is formed, okay? And bone is actually the process of bone formation. The process of bone formation is called ossification. And ossification is the process of a model of bone actually being made into bone, okay? Now there are two ways that this happens, okay? If you take a baby and you get an x-ray of a baby, you're going to find that there's a lot of places where it looks like there should be bone, but there's not, okay? And mom freaks out and gets all nervous about it and stuff like that, and you say, don't worry, mom, the bone's there, and it is. It's just in a cartilage model, okay? It starts out as a cartilage model. And there's two ways that that bone will form, okay? One way is called intramembranous ossification, And if we remember when we talked about flat bone, when we talked about flat bone, we had an outer table, an inner table, and that outer table, inner table was then filled in. That outer inner table was basically that cortical, dense, compact bone, and that inner table was made of cancellous bone, sort of like a sandwich, okay? And that's what happens. So intramembranous ossification is where bones form in flat bones, like the skull, the mandible, you know, the fat part of the mandible, ribs, the clavicle, a little, and parts of the clavicle, the sternum, and basically I have an outer shell. If we look at this image up in here, if I look at this picture up in here, there's an outer portion right here, an inner portion right here, and then the middle is basically this cancellous bone that's in the middle. And it starts out, it ossifies the process of becoming a model to be able to becoming a bone by what's called intramembranous ossification. If you look at a baby, you know, don't touch the soft spot. Basically, that's going to fill in. It's going to fill in by this intramembranous ossification to create an outer plate, an inner plate, and cancellous spongy bone in between. Okay, and that's occurring in flat bones. But you know what? That's not the most common thing. The most common way that bone forms, okay, is what's called enchondral. Oops, I shouldn't have done that in red. Let me get rid of that. Okay, let me get rid of the red. Let me do it in yellow so it's able to be able to see it. It's called enchondral or endochondral ossification. And this is where we actually have a bone like we see here, okay? Like we see here, which is basically a hyaline cartilage model. Okay, it's there. You just can't see it radiographically because it's not dense. In other words, things that are more dense or harder are whiter. Things that are less dense are grayer to blacker. Okay, so basically there's a hyaline cartilage model of that particular bone that's there. Okay. And what happens is within that bone, there are what are called ossification centers. Let's say that the center portion of the bone right here would have an ossification center, which is usually called the primary ossification center. And there might be another area out in here and another area out in there, which are called secondary centers of ossification. At the right time, chronologically in development, okay, what will happen is you start to see those areas start to ossify. So in other words, a primary ossification center will start to show some level of ossification. Okay, and then at a certain other time, you see those secondary centers start to ossify. What's going to happen is as they get older, as the child matures, and the infant and the child matures, what's going to happen is those primary centers of ossification gets bigger, the secondary centers of ossification get bigger, and eventually they grow together by interstitial and appositional growth. When they touch each other, actually, then all of a sudden they fuse and they become one solid bone. Okay, and that's called endochondral or enchondral ossification. If you actually look at a baby, you'll see at a certain age, you'll see a long bone, you'll see a part in the middle, and you might see a little bit at one end and at the other end, which actually come in at different ages. In other words, there's a chart which you could actually look at to see when these primary and secondary ossification centers develop, okay, or when you should start to see them radiographically, so you can actually determine the chronological age of a child by when these ossification centers start to be appearing radiographically, okay. So those are the two ways we ossify, either by intramembranous ossification in flat bones, which is not the most common type, or endochondral or enchondral ossification, which is through a hyaline cartilage model that ossifies by various ossification centers that continue to grow until they finally meet, and when they get appositional to each other, or when they touch each other, then each of them will stop and they become one, okay? And basically that's the most common way we get ossification occurring. Okay. Now, We talked about tissue before, and we mentioned that bone is a connective tissue, but it's more than that, okay? What happens is we know that bone's part of a connective tissue, but involved with bone, we also have cartilage, okay? That cartilage which is basically either the model of bone, or at the end, if we talked about our last in regards to bone structure, articular cartilage at the end of bone, okay? And that's also a part of connective tissue. Again, what do we know about connective tissue? Few cells, lots of matrix. Few cells, lots of matrix. Bone is a connective tissue we talked about before. The periosteum and the endosteum, okay? And these are the cells that are osteoprogenitor, that have the ability to be able to make bone, okay? They have cells in there that are able to make bone. And basically they are connective tissue as well, so they are part of what we're talking about here, bone as a connective tissue. And the bone marrow, okay? The bone marrow fills the spots between that cancellous bone. If we talked about cancellous bone or that spongy bone, what happens, they have struts that are going all different directions. These struts are going in multiple different directions. And a lot of these struts are lined up like next to each other, and those are called trabeculi. We'll talk about that later on. But what happens is I have all these open spaces between, all the open spaces between. So what happens is we start to fill those open spaces with material inside. So we start to fill those areas with material inside. Okay, and that's fat or other bone growing cells, such as bone marrow, that sits in there that actually is able to make blood cells. And so this bone marrow is either fat, and what is fat? Connective tissue. What are blood cells? Connective tissue. So basically that bone marrow is also considered as part of connective tissue. Okay, so it's more than bone. It's also the cartilage, the periosteum, the endosteum, and the bone marrow. Okay. Now, again, bone is a form of connective tissue, and what do we know about connective tissue? Just what I just mentioned, abundant matrix, few cells. Abundant matrix, few cells, okay? Little cellular material and lots of intercellular material. Now, what provides most of that matrix? It's about 25% water. So about 25% of the bone is still water, okay? Even though it seems hard, it's 25% water. About 25% is collagen. Now, we talked about collagen earlier in tissues, and we know collagen is basically strands of material that provide tensile strength, plus they're a little bit flexible. They will allow bending a little bit. And the bone actually needs to bend just a little bit. The bone needs to bend just a little bit if it was too strong. If the bone was too hard without ability to bend just a little bit of a give, any kind of stress to it would cause it to shatter, and it would break into multiple pieces. So we don't want that to happen. So that collagen is important. Also, collagen is critical when I start to lay down what's called these inorganic salts, or the hydroxyapatite, which I'll mention in just a second. So about 25% water, about 25% collagen, and it's about 50% of what we call crystallized material. And this is an inorganic material. It's not living. It's not living at all. Collagen, yeah, does have a living basis to it, where the crystals in the bone are not living, okay? And this crystallized material are basically multiple different types of inorganic mineral salts. And as collectively, these inorganic mineral salts are called hydroxyapatite. So if you're hydroxyapatite, that's a conglomeration of all the mineral salts that make up the hard part of bone, okay? It's mostly calcium phosphate and calcium carbonate. So again, the key word there that we see a lot of is calcium in both of them, calcium carbonate and calcium phosphate. And true bone is largely calcium. However, we do find in bone a lot of magnesium hydroxide, which is there. In fact, magnesium is chemically exceptionally similar to calcium. If people have a calcium deficit, sometimes by giving a magnesium, it makes up the difference of the calcium deficit. It does almost the same type of stuff. So magnesium works very close to calcium. When people have kidney stones, the majority of the kidney stones are calcium. Guess what another common type of kidney stone is? Magnesium, because it's actually very similar in chemical nature to the calcium. We also have another mineral salt that's in bone called fluoride. So fluoride is another mineral salt. If you look at, you'll see communities used to fluorinate their water, and they put fluorine, a certain level of fluorine in the water. That was actually to try to stimulate the development of hard bones, so kids would develop harder bones, okay? If you look at toothpaste, fluoride toothpaste, and the fluoride toothpaste is going to make the teeth harder as well. So it's actually a hardening type of a material. Also sulfates are in there as well, okay? Too much fluoride actually, hyperfluorosis actually causes bone to be too hard, and when bone becomes too hard, it becomes what? too brittle. It breaks easier. Okay. Now the important part about these crystals, these hydroxyapatite crystals, is they require a collagen matrix to be able to form. Okay. So the bone has to have this collagen matrix, or this lattice work, or this web of collagen fibers to allow something for those crystals, calcium phosphate, calcium carbonate, the magnesium hydroxide, blah, 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 to be able to form on. If they don't have that, it won't work. Okay. If in older houses, if you ever done any reconstruction in older houses, they used to do plaster and lath. That instead of having drywall, before drywall was created, they used to put boards, very thin boards from stud to stud, and that was called lath. And that provided a matrix so I could take the plaster and put the plaster on to make it hard on the outside. I remember when I was a kid, you know, the house I had was basically plaster, that I lived in was basically plaster and lath. Okay. And if you hit the wall, you can't replace it with a piece of drywall because drywall wasn't around then. But basically, you had to take plaster, fill in the hole, and it would be on top of these bars, these lath wooden bars, which was that lath. Okay, so for the crystals to deposit in bone, they need a collagen fiber matrix. If they don't have that, it won't happen. So they need that collagen fiber matrix to be able to crystallize and harden on the bone. Okay, and basically that's what we call, again, calcification. This is initiated by something called osteoblast. Now, osteoblast sounds very much like fibroblast, and there's a reason why it does. You know why? Because they're basically the same. Fibroblasts work in more soft tissues. Osteoblasts are sort of like a specialized form of fibroblast that works in bone, because osteo means bone. And that's what the osteoblasts do. They lay down that collagen matrix so that we could crystallize. That's what the osteoblasts do. We'll talk about that in a second. So then, going back to bone as a connective tissue, abundant matrix, water, collagen, and a lot of crystals. Mostly crystals, over half crystals. Okay, and we talked about that, those crystals being hydroxyapatite. And what we have also, the thing that we forgot to talk about, cells. Okay, and these cells are widely scattered, and they're scattered, and they're arranged in rings around what's called a central canal, which I'll show you about in a short time. Okay. Again, I think a couple important points that I need to make about calcification. Number one, occurs only in the presence of collagen fibers. If I don't have collagen fibers, you're not going to put the calcium down. Or you don't have any framework on which to lay down the calcium. Okay. And what happens is, once I do have that framework of those collagen fibers laid down by what? Osteoblasts. Okay, those mineral salts now have a lattice work on which they could fill in those spaces, and that's what we call crystallization or calcification. Okay, so the spaces are filled with these mineral salts, the hydroxyapatite, that accumulate and solidify around the collagen fibers, and that crystallization is actually what causes the hardness in bone. But for the hardness of bone to occur, I need what? I need the collagen fibers as a matrix or a lattice work around which to allow those crystals to form. Okay. These collagen fibers are basically the organic component of bone, like we talked about. They're spit out, and they're made, and they're produced by the osteoblasts. Okay, and they're important because, again, not only do they provide a lattice work so I could crystallize or harden around that lattice work, but they do provide the bone with some flexibility and provides tensile strength. Bones will actually bend a little bit. Okay, and it's interesting because of that, of the collagen fibers in the bone, they're able to bend a little bit. Now, the bone you have today is not the bone you had a year ago. The bone's constantly replacing itself. It's not like one day you wake up and you don't have a femur. I can't come take my exam today because I woke up and that was the day that they took my femur. No, it's not like that. Okay, but small little pieces of bone are constantly being replaced. The older portions of bone are constantly being replaced by new bone. Okay. And the way it happens is the bone bends a little bit. When the bone bends a little bit, the collagen, it actually creates an electrical current inside the bone, which is called a piezoelectric current. And that piezoelectric current starts to take bone away from certain areas and deposit bone in other areas. Okay, so I need that little bit of flexibility. Also, that little bit of flexibility prevents the bone from fracturing by small levels of trauma. Okay, it allows the bone to bend a little bit of a buffer. You know, it's sort of like, I know my grandson, who's 8, he had just had a birthday a week ago. And what did my son buy him for his birthday? He bought them a trampoline. So now they have a trampoline in the basement. Well, you know, they could have gone in the driveway and just sort of jumped up and down in the driveway, but the trampoline's better. Why? Because it gives a little bit, okay? So it provides that flexibility in that surface, actually prevents him from getting injured. If he was out there bouncing around on the driveway all the time, guess what? There's a great chance of injury and things like that. Where basically a trampoline, he could jump all day and tire himself out and go to bed at 8 o'clock or whatever the case may be, and it's good. So that the collagen actually allows the flexibility of the bone, which is protective. It also provides tensile strength, so it's hard to pull the bone apart, okay, from one end to the other. So that's what the collagen fibers actually, when they work pretty well at there. Now, when we look at the cellular structure of bone, okay, and I think that's important to talk about, I have actually 4 different types of cells that we have to be concerned about. One are called osteoprogenitor cells, okay? Another one's called osteoblasts, osteocytes, and osteoclasts, okay? Osteoprogenitor cells are cells that are the premature, primitive type cells, and they come from something called mesenchyme. Mesenchyme basically is embryonic tissue, which is basically another word for like stem cells. Okay, and what happens is mesenchyme has cells which are pluripotent. Pluripotent means that they could be a lot of things. However, when they're in the endosteum, which we talked about, the membrane that lines the inside of bone, as well as the periosteum, that membrane that covers the outside of the bone, they're pluripotent only in the form of making bone cells. So they're not really pluripotent, they're maybe what we call osteopotent. Maybe that'd be a word. I don't know if I've ever seen it, but it sounds like a good word. You heard it here first, okay, folks? You heard it from me, okay? And what happens is the cells, a number of the cells in that periosteum and the endosteum are osteoprogenitor cells, which means that they're able of and capable of producing new bone, because the cells in them are from mesenchyme or embryonic cells, i.e. type stem cells, okay? And that's what we call these this osteoprogenitor cells. And we do see them in that periosteum and endosteum, the membrane outside the bone and the membrane that lines the inside of the bone. The other types of cells we get are called osteoblasts, and osteoblasts are bone building cells. We see some osteoblasts there, and I don't think most like how I could tell those osteoblast cells, because it says it right here. Okay, I probably wouldn't be able to tell that a whole lot. And basically, these are bone building cells, and these are the cells like fibroblasts. Fibroblasts make collagen and other fibers. What do the osteoblasts do? They make that lattice work on which I could crystallize, like we talked about previously in the previous slide. Osteocytes are the cells of daily activity. Once a cell grows up, okay, it becomes an osteocyte. It gets locked in place, and it basically does the normal daily everyday work of a bone, and that's what the osteocytes do. Nothing more, nothing less. They have a certain lifespan. They can't multiply anymore. They can't divide. They're basically sitting there for the duration, and eventually they're going to wear out, and they're going to actually be taken away. They're going to be gobbled up. What gobbles them up? Osteoclasts. Osteoclasts are cells that actually go in that start to break down the bone. Now here's an osteoclast up in here. See the size? It's huge. What osteoclasts are is like these things called macrophages. Macro means big, phage means to eat. And basically these osteoclasts basically are larger cells that are actually fusion of of monocytes. Monocytes are white cells that actually will eat other things up, okay? And they become this large cell, which is called a macrophage. The macrophage is filled with certain tasty things like enzymes and acids that will be able to absorb or dissolve the bone, okay? So I have to take the bone away before I put new bone down. So I'll talk about that in just a second. Let's talk a bit more about individually about those things. Let's first talk again about the osteoprogenitor cells. And these are, again, derived from mesenchyme, which is embryonic tissue, which is, and mesenchyme is basically a precursor to all connective tissue. All connective tissue started out as mesenchyme. And this mesenchyme, this embryonic tissue, is basically, like we say, a stem cell. Stem cell is an undifferentiated cell. It's just sort of, it looks like any other mesenchymal cell. In other words, you can't tell the difference of one embryonic mesenchymal cell from the other until it decides what it wants to do underneath a particular stimulus. When it's stimulated in a certain way, it's going to start to develop into a certain type of cell. Once it starts down that path, there's no turning back. It can no longer divide. Mesenchymal cells, embryonic tissue, stem cells, they do divide. Once they start down a path to become an adult type of cell, guess what? They can't divide anymore. There's no more mitosis in those. But these osteoprogenitor cells, embryonic cells, mesenchymal cells, stem cells are capable of mitosis. They are able to divide, and that's how bone gets regenerated. Okay, about 1 to 2% of all the cells in my bone marrow are stem cells, And these stem cells could become a number of different types of blood cells, red cells, white cells, platelets, because they have that differentiated yet. They look like nothing special, but eventually they will become something specific, okay? So these osteoprogenitor cells, embryonic cells that have no at that time direction until they're told what to do, and then all of a sudden they start to become bone cells. They differentiate or develop or progress to become more different, to become bone cells, and until that point, basically, they can divide. Once they start to head on that road, they can't divide. And again, these osteoprogenitor cells are in the endosteum, the periosteum, and cells lining various canals inside bone that have blood vessels. We'll talk about that in a little bit when we talk a little bit more about the deeper structure of a, okay? Osteoblasts. And osteoblasts, like I said, are bone building cells, okay? They're very much like specialized fibroblasts. Fibroblasts more in softer tissue, connective tissue. Well, I can't say connective tissue because bones are connective tissue. Should have hit me and say, oh, that's not right. Okay, and softer tissue. Well, they're like fibroblasts. And what they do is they're capable of laying down new bone because what they do is they synthesize and secrete collagen and other organic components that make that matrix or that lattice work on which they can have crystallization occur. Okay, by doing that, by laying down that lattice work, they're able to initiate calcification, because without that lattice, without that matrix, calcification will not occur. Okay, so that's what these osteoblasts do. Now the osteoblasts, you can see up in here, here's some osteoblasts making bone there, osteoblasts making bone again. I wouldn't be able to figure that out, but anyway, that's what it is. What the osteoblasts do is they're not the smartest cells on the block, okay? Because, and maybe this was initially planned that way. What happens, it's like painting a room floor. Let's say you're going to paint a floor like in your basement or something like that. Well, here's what you don't want to do. You don't want to go ahead and start out by painting the outside rim of the floor, okay? And then you say, okay, I'll do another layer. You start to paint another row inside that. You say, let me do another layer, and you paint a little bit more on the inside. And you do another layer, and you paint a little bit more on the inside. And next thing you know, guess what? You're sitting right here in that center, and you can't get out without walking across the wet paint. Well, exactly what happens with these osteoblasts. They start to secrete this matrix, and they secrete a matrix around themselves, and eventually what happens is they get trapped inside that matrix. They get trapped by the secretions, by their secretions inside the center of that matrix. At that time, they say, I can no longer lay down any more matrix because there's nowhere else to go. And there's a small little container or a lake that they sit in. Lake, remember that, it's going to come up. Small little lake that they sit in. And as a result, they say, my job is done. And they say, nope. What we want to do is we want you now to assume the role of an osteocyte, which is basically a cell that's going to do the everyday, normal, run-of-the-mill type work of bone cells. Okay, and so that's what osteoblasts do. They're there to lay down and make new bone. What we have then are osteocytes. Okay, now what happens is the osteoblasts become locked into small little lakes. These little lakes are called lacunae. Lacunae sounds like lake, lacunae. And if we look at this picture, this image down here, if I look at this image down here, all these little dark areas in here, those are little osteocytes. It's all little osteocytes. You see how they're arranged like in rings around? Now the center portion right here, this area right here, is called the Haversian canal or the central canal. And that has the blood supply, both coming in, arteries coming in, or arterial blood coming in, and venous blood going out, as well as nerve and lymphatics that sit inside this central canal or Haversian canal. So as a result, what happens is we start to build rings of bone around that central canal. That's called a Haversian system. I'll talk about that in a little bit. But the osteocytes, getting back to them particularly, and all those little dark spots, every little time you see a little dark spot in there, that's an osteocyte, okay? And it's very characteristic, and here's the osteocyte. You see an osteocyte, 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 osteocyte. Okay. Anyway, what happens is if we think about that, it's very characteristic of connective tissue. Why? Few cells, lots of matrix. All that matrix is all that stuff in between. It's all that crystalline material laid down on a collagen lattice work or matrix, or lattice work or ladders and stuff like that inside there. Okay, so what happens is these osteocytes, like I mentioned, are the mature bone cells. They're the ones that they're adult, and what they do is they maintain the normal daily cellular activities the bone. Okay, they have metabolism. They make things. They make products. They make waste. That waste have to be gotten rid of. So is basically they're there to both do things as well as to get rid of waste. So there's exchange of nutrients and waste from those osteocytes. However, like I mentioned before, once they headed down that quote osteoblastic road before becoming osteocytes, once they head down that road, there's no turning back. There's no cell division. They can't divide. Okay, so therefore they certainly run a lifespan. And then what happens to them when they finally get old? Don't look at me that way, please. Don't look at me that way. Let me get rid of myself for a minute. So now you can't look at me. Okay, you can go ahead and look at me. What happens when they get old? I have to get rid of them. Okay, get rid of them. Osteoclasts. Now we have osteoclasts that come in. Now osteoclasts are actually from the fusion of lots of monocytes. And again, the monocytes come together, and monocytes are eaters. They're white blood cells that will gobble up debris, bacteria, and all kinds of stuff just to get rid of them. So they have a tendency to be quite large cells. And they're filled with all those lysosomes and other types of enzymes and acids. They're able to break things down or dissolve it, to sort of like wear it away. Okay, and if you look here, these larger cells in here, these are osteoclasts. These are like oh, that's an osteoblast up there. They don't have an osteoclast here. Okay, this is an osteoclast there. That's an osteoclast there. They're quite large cells. Okay, and basically what happens is these osteoclasts are going to come in, and with the acids and the lysosomes, they dissolve inorganic material. So they're going to eat away all that lattice work, all the hydroxyapatite, all the crystals and stuff like that. And then they also phagocytize the organic material, such as the old, oh my gosh, they're eating their own, you know, like the osteocytes and the cellular elements and stuff like that. They get rid of them. To be able to put down new bone, I need to take away the old bone. You can't keep on laying down new bone, because then all of a sudden we're going to be all bone and nothing else. We have to take away old bone to be able to lay down new bone, and that happens all the time. Now this process of osteoclast is called resorption. Okay, osteoblast, deposition, osteoclast, resorption. Okay, in fact, when we have a fracture, this is sort of interesting. When a fracture heals, okay, and I could spend like a whole video just talking about fracture healing. When a fracture heals, it bleeds at the end of the bone through mostly the cancellous bone, okay? Because the cancellous bone, we know that spongy bone is much more bloody than cortical bone, which is very dense, okay? So what happens, the bone will bleed, and the bone actually creates a hematoma or a clot that connects the two sides of the bone. So the two areas of bone, the fracture here, the fracture here, they come together, and they're held together initially by a clot. And that clot's really important because what it does is it allows small capillary buds, which are small little vessels, to work their way across and build themselves up across the clot, so they become combined. So they create and reestablish a blood supply across that bone. Okay, again, the blood supply is not great to start out with, but they still reestablish that blood supply across the bone. That's important. Why? Because I have to have cells then come in. If there's no route, if there's no road to get in there, cells can't get inside that area of the fracture to either take away old bone or lay down new bone. So after a fracture, the first thing that happens is once these capillaries are formed with this quote fracture hematoma or callus that holds the bone together, the first thing that happens is osteoclasts start to work in. And what do osteoclasts do? They come in and take away the ends of the old bone where the fracture was. I used to hate it when I'd have a patient with a fracture. They'd come in, and the first day was always nice. You see the fracture, and you put the fracture up on your computer at a digital X-ray, or you put it up on a screen if it was regular film, you know, years and years ago, and you'll show them the fracture, and it looks like a very sharp, dark line across the bone where you can see the loss in continuity of the bone. And you show them where it's at and stuff like that, and you treat them whatever you have to do, whether it be a cast, a splint, whatever the case prays, surgical correction, whatever the case may be. Okay. Then what happens is I used to always have them come back in 2 weeks to take another X-ray just to sort of evaluate how they were healing. I hated for them to see the X-ray. I'd have them go get the X-ray before they came to the office. I'd look at the X-ray before they got back to the office, and I'd look at it and see what it looked like. And I look at it, and I always hated to show them. Why? Because at 2 weeks after the fracture, what's happening? That blood vessels have reestablished themselves across that fracture line, and the osteoclasts are coming in. And what do osteoclasts do? They take away bone. So the area where the fracture was, where it was nice and sharp and very well defined, 2 weeks later is very hazy and wider. Okay, looks wider and hazier. So I'd show up and they say, well, what did the x-ray look like? I said, looks good, looks good, looks great, everything's healing just like it's supposed to. I say, can I see it? I used to say, oh, geez, do I really want to show them? Yeah, let me show them, because they asked for it. I can't keep a secret. So I put up the x-ray or put it on the computer and stuff like that and say, here it is. Say, hey, doesn't that look worse? Doesn't that line look bigger and wider and hazier? I say, you're absolutely right, but it's working, it's healing. And they say, yeah, right, this guy knows what he's talking about. Actually, I was right, okay, and they were wrong. And the reason why is for the bone to heal, I have to take away the old bone. And that first couple weeks after, what happens, the osteoclasts come in to dissolve. In fact, if we think there's a fracture and we can't see it radiographically, I would treat it like a fracture, have them come back 2 weeks, take another x-ray, and guess what I'd see? I'd see areas of resorption around that site of the fracture. Why? Because the osteoclasts were doing their job. Okay, and they were taking away the old bone so I could lay new bone. Once that old bone is taken away, guess what follows? The osteoblasts come in, and the osteoblasts come in through that network of vessels that were initially formed, and they start to lay down what? Collagen fibers, and that matrix, those fibers that provide a lattice work, so that now they could actually start to have crystallization occurring around that lattice work. So I have to take away bone before I put down new bone in repairing in bone repair. Very, very, very logical. Okay, and then finally everything gets back to normal. The bone and the bone will continue to remodel for anywhere from 6 to 9 months to sometimes a year, depending upon where the fracture is after the fracture occurs. So there's going to be constantly changing the bone for a period of time. Okay. Anyway, so that's what the osteoclasts do. So now we know what osteoprogenitor cells do, what osteoblasts do, what osteocytes do, and what osteoclasts do. Okay, and that's an osteoclast. Those osteoclasts there. That's not up there. That's not. They look like an issue, but no, they're osteoblasts. Okay, osteoclasts, again, large macrophages. Okay. Now, we talked about this a little bit before, but I think I should show you again so you could understand this as well. We talked about compact and versus spongy bone. Compact bone, okay, compact bone, okay, is also called cortical bone or sometimes called dense bone. Sometimes we'll use the word dense as well. Dense. Okay, dense, compact, cortical, sometimes hard. Some people say hard bone. And if we actually look at the bone here, you can actually see what it looks like. If you look at this area right in here, you see a very thick, very dense looking bone. And again, we know that this is the diaphysis. We should know that from the last video. The diaphysis, which we know has a very thick cortical rim around the outside, so that's nice and thick, and that's the cortical bone, the compact bone. When we get into that metaphyseal region, like we see it says metaphysis here, you can see how that cortex becomes thinner. And then finally, when we get down in the area of the epiphysis, we have a very thin epiphyseal shell, or a very thin cortical shell. And then finally, we get down towards the metaphysis again, and now it's starting to widen out again. And so that's that cortical, compact, dense, hard bone that's largely in that diaphyseal region of the bone and becomes much thinner in the area of the metaphysis and the epiphysis, which we talked about before. The second type of bone that we have is what we talked about before, that spongy bone. Spongy bone is also called cancellous bone. It's also sometimes called trabecular bone, because trabeculi are trabeculi are basically these little spikes in bone, okay? And these little spikes, the way they line up, provides considerable strength. So when we look up in here, you say, that's all spongy bone up in here. How strong could that be? Well, most fractures of the femur will occur right about in that area right there, because that's because of osteoporosis. But in normal, healthy bone, what happens is the way that those little bony spikes line up is they line up in according to areas of stress. And the areas of stress, they provide considerable strength to bone, and they're also lighter weight. And they could pack this with more what? More marrow at the ends, okay? So as a result, it's not that it's really, I used it a couple times, and I hate to use the word soft bone because it's really not soft, but it's spongy bone, cancellous bone, trabecular bone, sometimes also called medullary bone, because this is the medullary canal. The center of that is called the medullary, or sometimes called endosteal, because this is the medullary or endosteal canal that's in there, and that's filled with that spongy cancellous trabecular bone that sits inside there. Some bones, like the heel, the calcaneus, has a very thin cortical shell, and it's all, almost the whole inside is all cancellous bone, very spongy looking. Okay, so that's the difference between cortical, compact, dense, hard bone versus spongy, cancellous, trabecular, medullary, and osteo bone. Okay. Now, I want to sort of tidy all this up in the last few slides, talking about the structure of compact bone. If I'm looking at the picture on the top, okay, the image on the top, this area right here, let me use a different color. This area right here would be the area of the endosteal canal. And you can see how those little spicules of bone, they point in different directions. Those are called trabeculi. See, it says trabeculi right there. Those are all those little spicules, and they're lined up in a certain way that they provide strength. But we're not going to talk about that. Let's talk about the structure of compact bone here, okay? And what compact bone is basically it's comprised of what we call osteons, okay? Osteons, okay? And an osteon is basically the circular cores of bone. There's one, there's an osteon here, osteon there, there's an osteon there, here's an osteon out here, osteon there, osteon here, and they're basically sort of like a core of bone, okay, a long core of bone, okay, and basically what they are is they're concentric layers of matrix, okay. If I look down here, what we see here at the bottom, okay, is this area right here is that center canal. That's this little area right there with the artery, the vein, the nerve, lymphatics. That's called the haversian canal or the central canal that goes right down the middle of that osteon. It goes right down the middle of it, okay? And that's called that central canal or haversian canal that goes right down the middle. And if we look at the way this osteon is provided, it can actually look like rings of trees. And these osteocytes are these little blacker areas that are out here that are arranged in a circular fashion around the central canal, okay? And so we have concentric layers of what are called lamellae. Like if something's laminated, it's a layer, okay? So lamellae are layer upon layer upon layer upon layer, and that's what we see. We see layer upon layer upon layer like the rings of a tree, okay, in these osteons, okay? Now what happens is inside those rings are little lakes, okay? And these little lakes are called lacunae. I mentioned that before. And what happens is if I look, here's a osteocyte, but they're actually sitting inside a little lake, and that little lake is called a lacunae, okay? Now, if you look at those little areas, what you're also going to see is besides the ringed type of appearance, you'll see all these little spidery-like legs coming out from the area of the lacunae. These little spidery legs coming out, okay? They're going this way, okay? All across the bone. So you have the rings going this way, but then you have these little legs coming out. Those aren't really legs, okay? But what they are is they're small canals. And those small canals, okay, the small canals are called canliculi. They're called caniculi, or small channels. And what they do is they connect one lacunae with an osteocyte inside the lacunae to another lacunae with another osteocyte inside the lacunae. You got to remember this. That what happens is cells need what? They need nutrients, they need oxygen, they need nutrients, they have to get rid of waste. How do they do that? The blood system. Well, guess what? Where are the blood vessels out here? There's not many there. You can't see them, okay? They're not there. I'll show you. We could get to those central canals, but that's only a special way. So how do I get the nutrients out to the peripheral osteocytes in those rings? Very simple. The central canal with the blood vessel allows nutrients like oxygen, other nutrients to leak out of the vessels inside those little central canals, haversian canals. And what they do is they go through those series of small canals called the canliculi that go to the area of the lacunae. So therefore they provide the nutrients, to the lacunae from the inside out. And again, the canliculi of one lacunae here with one osteocyte leaks with another canliculi to another lacunae with another osteocyte, which then would go out to another one further out in the ring. So I'm able to get nutrients all the way out in the periphery in this particular osteon, okay, by all these canliculi linking lacunae to lacunae to lacunae, and they get the nutrients from that central canal that then leaks out to the canliculi to the periphery, to the outer rings, okay? And that's how we get the blood supply, as well as taking waste and going from the outer rim inward. Again, how? through the canliculi to go from the outside to the inside to that central canal, from the outside to the inside through those canliculi, from lacunae to lacunae to lacunae. Okay, so basically these lacunae are filled with that extracellular fluid. Okay, and also they have a lot and various wastes and stuff like that, nutrients and waste to both supply as well as something to relieve. Okay. And again, the canliculi connect one lacunae to another, to another, to another, and eventually they all link back to the central canal. So they get nutrients in the central canal out through the canliculi to subsequent lacunae in those concentric circles around there. Okay. Now that again, that haversian canal runs longitudinally up the center of that osteon. Right up the center of the osteon, and we see it right here. Probably a better one to look at, let me get rid of all these lines up in here, would be the better one to look at in this situation is this one right here. Let's look at this osteon. We only get like half of it, okay, because we see that central canal, that haversian canal running right there with the artery, vein, nerve, and lymphatics that are running through there. Now what happens is blood has a difficult time getting into bone, and the blood comes in from the outside, from the outside, but what we call a nutrient artery. Nutrient artery. It comes to the outside. Now, usually in long bones, it doesn't. There's not many of these. There are a couple little spots. You actually see a small little hole on the outside where that nutrient artery will go into bone. Okay, they're not a lot of places. They're just isolated in various areas throughout the bone. So it comes in from the outside, and what happens is then the blood vessels will branch off, and when they branch off, they're actually going to go through transversely directed. Let me change the color here so you get easier. Goes transversely across the bone through what things called Volkmann's canals. And these are Volkmann's canals. So if you look here, that's a Volkmann's canal, that's a Volkmann's canal, that would be a Volkmann's canal. They go from side to side. And what they do is they connect that central or haversian canal to another central haversian canal. So I get that blood going from side to side from one osteon to another osteon through those Volkmann's canals. And then what happens, they lead into that central canal with the blood vessels, which then provide the blood supply and the nutrients and the oxygen and remove waste from all the osteons, or from all the osteocytes in that particular osteon. Okay. So that's what we see with these Volkmann's canals. And again, here's a Volkmann's canal, Volkmann's canal, Volkmann's canal, and then if I look at that haversian canal, that's the haversian canal. So haversian canals, as I can see here, run longitudinally. Volkmann's canals runs transversely. Okay, through the center. Okay, and that's how we provide nutrients to the bone in our compact or cortical, dense, hard bone. Okay, and that's called that's called haversian system. Now, when we look at that structure of hard bone, again, we have a bunch of different. Again, we have that lamellar structure, that area with rings, but also it's a little bit more than that. I have multiple different types of lamellae, okay, which are multiple different layers. The first type of lamellae I have, okay, are called concentric lamellae. And these are my concentric lamellae. It's around the osteon. We have a ring around a ring. Let me do a different call. Let me do that differently. Okay, let's do this. Let's get rid of that. Let's do this. Show you. I have a ring and a ring around that, and a ring around that, and then a ring around the outside of that. So they get bigger and bigger rings, okay? And they're around the haversian canals. And those are called concentric lamellae. You can see where the little arrow goes, concentric lamellae, and they're around that haversian canal, okay? That's the first type of lamellae that I have. Second type of lamellae I have are called interstitial lamellae. And the interstitial lamellae fill spaces or fill areas between the osteons, okay? So if we look here, let me go back and show, let me draw. Here's an osteon here, and here's an osteon here. Well, guess what? There's this little triangular area in here that's not filled in, and that's filled in with an area of what's called an interstitial lamellae, okay? And they are remnants of prior osteons that haven't been totally resorbed, okay? And that's what these little areas are. And we can see, like, there's a little one in here, little interstitial lamellae, and basically they're just those little areas between the concentric lamellae, okay? Besides that, you have what's called the outer circumferential lamellae. I shouldn't have done that. Outer circumferential lamellae, and that's around the outside. So when we look around the outside, there'll be there'll be a rows. Here's a row here, here's a row here, here's a row here, here's a row here. And basically they encircle the entire bone around the periphery of the bone, just under the periosteum. I know the periosteum is the outside membrane. Okay, well, if I have an outer circumferential lamellae, I also have an inner circumferential lamellae, and that's going to be in this area right here. So basically, it's the area right here. This row of osteons, or this row of lamellar structures of the bone that are on the inside. So basically, I have my concentric lamellae. Okay, my concentric lamellae. Okay, I have my interstitial lamellae. I have my outer circumferential lamellae around the outside, and then I have my inner circumferential lamellae in this area. Okay, and basically that's the structure of compact bone. Okay, that's the outer portion of the bone, like we talked about in the diaphysis and stuff like that. Okay, again, this is the same thing, and this actually shows what we talk about a nutrient foramen. Okay, where this is the same image that I showed in the last one, and this just shows how a nutrient foramen will enter a bone in a certain area. This is the tibia. Okay, this bone down here, you can't see it. Let me just do it this way. This bone right here is the tibia, okay? And this area right there is the area where the nutrient foramen enters. So you can actually see it's not a lot of them. There's a few of them in a couple strategic areas in the bone, okay? And basically, once it gets inside that, then we have to go through the Volkmann's canal to go to one osteon to the other, and that ends up and that connects into the Haversian canals that connects one osteon to the other. And it supplies, that nutrient artery supplies the blood supply to the bone, okay? I mentioned this before, and I should mention again, is the osteons basically are aligned according to lines of stress, okay? And it's hard to see, and we'll see this a little bit more when we show some radiographs. It's easier to see radiographically than it is on bone this way, okay? What happens is the osteons in the shaft are aligned parallel to the long axis. So this will be long axis is running this way, and what happens, the osteons will line parallel to the long axis. And what does it resist bending or fracturing? It works better. If they went sideways, they'd break, they'd pull apart as the bone would bend. If the bone was trying to bend this way, the bone starts out straight and you try to bend it this way, it's going to crack across that area. By them going this way, they will go with the flow, and they will bend with the bend of the bone. So they resist the bending or fracturing, okay? And the lines of stress change or modify according to the stress in the bone. And we're going to see this later on. We start to look at how bone is laid down. We'll see certain areas where the cortical bone is going to be thicker in area where they need more support or more stability, and will be thinner in other areas. Okay, and that's going back more about the structure of compact bone. So the bone is going to look different in different areas in regards to where that compact bone is or where it isn't, based upon where it needs it the most. If it needs more support and more stability there, yeah. If you think about it, okay, if you take a pencil, okay, if you have a pencil that you don't like, okay, pencil that maybe like put some bad answers on a previous exam, and you want to get rid of it, okay, if you take that pencil and hold it between your fingers this way and bend it, where's it going to break? It's not going to break at your fingers here. It's not going to break at your fingers, at the other side. It's going to break in the middle of that pencil, okay? And the same thing if I take a bone and try to bend a bone this way, where's it going to break? It's going to break somewhere in the middle. So therefore, the cortex is going to be thicker here to try to resist that bending and breaking, okay? And that's how the bone will change according to the stress that are applied upon it. Now that spongy bone or that cancellous bone performs what are called trabeculi. I mentioned this before, and those trabeculi are internal beams. Now, with this radiograph, this is a hip radiograph, okay? And basically, there's in the cancellous bone, it's not an osteonal structure, not that same core. Basically, it's these struts, okay? And we have multiple little struts all over the bone, okay? That run in different directions, okay? And these are, instead of being collagen like I had before the matrix, this is actually bone, okay? So there's no real central canal, there's no Haversian structures, but what happens is then this area in here is filled with marrow, either red marrow in areas that are actually producing blood cells, or more of a yellow marrow in areas that aren't, okay? And then the osteocytes actually lie still on the lacunae on the surface of these trabeculi. So if we look up in here, you'll see that there's like this is what it would look like inside there, and the osteocytes are just on the surface. Okay, the osteocytes are on the surface. Now, one thing I really want to show more so that on this X-ray, which I think is more important than anything else, is to look at these trabeculi. Now, again, if you look here, you see a very thin cortical shell on the outside. If I look down here, you actually start to see how the cortical shell is starting to get thicker. See how the cortical shell is starting to get thicker there? But what actually provides strength? Now, I want you to look at this really close because I can see it and I have old eyes. What happens is, see these white lines that are coming this direction like that? You see directions come, white lines coming this way, okay? And you see some coming this way. Those are called trabeculi. And those trabeculi are lined up according to lines of stress, and that's in cancellous bone. And the way that those trabeculi line up, they provide like struts that provide increased stability to the bone to prevent from fracturing. Again, the hip is a very common place to look at this trabecular pattern. In fact, years ago, before they actually had nowadays, if they want to measure bone density and look for osteoporosis, they use some type of a densitometer, which actually they go ahead and stick and evaluate the actual bone density radioisotopically. Okay. In the past, before they had that, what they did is they took a picture frequently of the hip, because the hip was a large weight-bearing bone, and would show evidence of osteoporosis, simply because by weight-bearing, it's going to be one of those that's going to be a little bit more resistant to osteoporosis, because it's again, bone will build up in strength according to where that strength is most needed, correct? Okay, so what happens is they used to take pictures of the proximal femur, okay, which is basically this area up in here. This is the femoral head. If we look here, here's the femoral head, here's the neck right here, here's the head, here's the neck. This is that greater trochanter that sits right here. Here's the lesser trochanter, we see it right there. But what they do is they take an X-ray of the hip and look at the trabecular pattern. What happens is, with progressive osteoporosis, they started losing all these little like lines, and they could actually have a grading index. It was called the Singh index, S-I-N-G-H, after Singh, who was the one that described that type of index. And they were able to look at and evaluate the level of, or approximate the level of osteoporosis. It takes about 20 to 30% of the bone actually being gone before they actually see radiographic evidence of osteoporosis, which is a little scary. Okay, but anyway, that's what the spongy bone looks like. It has these trabeculi, which are these internal struts that provide significant strength. Okay, to bone. Again, most of that spongy or cancellous bone is at the ends of the bone. Okay, if we look here and look in this, again, that going back to our femur from before, we find that mostly in the metaphysis and the epiphysis. This is all spongy bone here, and then we only have that core of that central, that medullary endosteal canal, which is basically filled with cancellous spongy bone, because they have more cortical bone in that area that resists that bending. Okay, again, so that's what we see with that spongy bone. Again, if I look at short bones, flat bones, and irregular bones, they have a thinner cortical shell, but they have a lot of cancellous bone inside. And again, like I mentioned before, those trabeculi, or those bony spikes, are lined up according and along lines of stress. They're internal struts that provide significant stability and strength for the bone. Okay. Also, what happens is, because they've removed a lot of that cortical dense bone, it actually decreases the weight of bone, and also supports and protects the bone marrow, which fills in all those little gaps. If I looked outside this cancellous spongy bone, you see how it looks like sponge. Well, inside all those little air holes is not really air holes. It's filled with other cells that are for bone marrow or for fat. Okay, they're filling all those little gaps inside there. So that's actually solid, okay, inside there, and that's that spongy bone. So what we've talked about today is a little bit more about the structure of bone, okay? The different types of cells: osteoprogenitor cells, osteoblasts, osteocytes, osteoclasts. We talked a little about the osteon, how the osteon is made, sort of like a core of bone with a central haversian canal. It gets its blood supply from Volkmann's canals that come from a nutrient artery from the outside. We talked about how the osteocytes are sitting in concentric circles around that central canal, or that haversian canal, sitting in small little lakes, and each of those lakes is connected to that central canal through other lakes, through small little canals called canaliculi. We also talked a little bit more about cortical versus cancellous bone and the significance of each of those, which I think is all important. Now, radiographically, when we get to the lab, you'll be able to see these densities. Cortical bone, because it's denser, is going to look what? Whiter. Cancellous bone, because it's not as dense, it's more filled with other soft organic material, such as the marrow that we find inside with the cellular material. It's going to look not as dense, therefore it's going to look grayer. Okay, and we'll show these a little bit more. You'll see the trabeculi on radiographs a little bit more, like you saw the one on the femur, the femoral head and neck a little bit before. But we'll see these a little bit more in the lab. But I think it's important to understand the structure of bone, because that gives you a good understanding as to when you start to look at radiographs and what you actually start to see. So, yeah, again, as in all of the videos, if you have any questions, make sure you let me know those questions. I'm more than happy to answer any questions that you might have. Just email me or ask it in one of our sessions. And if you don't have any questions, again, my advice is always to stay safe and stay healthy, and I'll see you next time.